Let's begin with our lecture of infectious medicine, and our today's topic is candidiasis. Candidiasis is the fungal infection caused by the fungi known as Candida. The Candida is the common pathogen that is normally present in the body. It is present in the skin, in the vagina, in the throat, and in the other parts of the body. But it is not capable of causing the disease unless the immune system becomes weak enough. So the Candida, that is the normal flora of the body, is capable of causing disease known as the candidiasis. So it is common in practice, and you see a lot of patients with candidiasis, and they have candida infection of different parts of the body. And the patients usually, they have low immune system or weak immune response that cause the growth or reproduction of the candida and cause the infection known as candidiasis. If you see the structure of the candida, it occurs in the two forms. We have unicellular yeast form, which is the bud form, which are gram positive, and then we have multicellular pseudohyphae and hyphae, which are these produced by the birds, yeast birds, and they are attached to each other. So in this diagram or slide, you can see both. These are the buds or the budding form of the candida, and then we have hyphae or pseudohyphae, and these are multicellular structure, and then the buds are the unicellular. So these are the two forms in which the candida exist. We have bud form, which is the yeast form, and then we have hyphae and pseudohyphae. Next, what are the different species of Candida? The most common species that is capable of causing candidiasis most commonly is the Candida albicans. So Candida albicans is the most common candidal infection. Then we have Candida krusei. This is the, all these, you can see the histological appearance of these Candida under the microscope. So these are the Candida albicans. You can see some budding forms. Then we have Candida krusei. This is the Candida tropicalis. Candida tropicalis. Then we have Candida lusitaniae. These are the Candida lusitaniae. And then we have Candida gularimondi, Candida parapsilosis, Candida Kaffir, Candida dubliniensis, and then we have Candida glabrata. So very common is Candida albicans. You see mostly the patients who have candidiasis, the causative agent or the causative species is the Candida albicans. So it's very, very common to have candidiasis caused by Candida albicans, and again it's the normal flora of the body present in different parts of the body, but only when the immune system becomes weak or low, these normal flora of the body, they become pathogenic and they cause opportunistic infections because of the weak immune system as a result of diseases like diabetes mellitus, malignancy, chemotherapeutic drugs, antibiotics, HIV/AIDS is very common. Even during pregnancy, the vaginal infection or vaginitis caused by Candida is very common. There is pruritus, itching, and curdy white discharge from the vagina. So these are, even in pregnancy, the immune system is weak. So all these conditions, they predispose to the candidal infection, and it's very, very common fungal infection. Next, again, how the spread of the Candida infection or Candidiasis occur. Here you can see we have the adhesion. This is the adhesion. The Candida or the fungi Candida, it adheres to the cells of the host, whether it's the epithelial lining or any structure, it attaches to that and it become adherent to that host cells. So this is the lining of the host cells and it becomes adherent to the host cell. Dimorphism, it exists in two forms. Di is two. So I already mentioned we have bud form, and then once it also gives rise to the pseudo hyphae or hyphae. So it exists in two form. It's both ways. The bud form change into pseudo hyphae, and then there becomes a bud form also. So it's both ways. Similarly, switching is both ways. White is the bud, and then opaque is the pseudo hyphae, and again its switching is the both ways in both direction. So after the adhesions of the Candida to the host cells, then the next step is the invasion of that host cell layer, and it causes damage or destruction of that host cell layer and cause deep invasion or deep infection. And this occurs by thigmotropism, and thigmotropism is the term used for the directional movement or the directional spread. So it directions towards the deep layer of the cells and it spreads downwards and cause destruction or the damage. So first the adhesion occurs, it becomes adherent to the surface layer because of the glycoproteins which are present in the Candida, and because of those glycoproteins it adheres to the host cell layer, and then it crosses the host cell layer, passes through the host cell layer and cause damage to the host cell layer. This is biofilm formation. Biofilm is the gathering, sticking one on top of the other, so it forms a layer on top, and usually it forms a layer on the catheter too. So in patients who are catheterized for a long time, they are very commonly predisposed to candidal infection also, because Candida forms a biofilm, a layer on top of the catheter like this, and it can cause infection. So that's the first adhesion. Then invasion, there is biofilm formation, covering adhesion on top of the layer or the catheter, which is the bag inserted for the urination. And then some traits, fitness traits, some traits which predispose to the candidal infection, we can say is the pH. pH is very important. Any change in the pH can predispose to the fungal infection, and that is because of amino acids which breaks down to ammonia, and ammonia cause pH regulation. Any any carbon, nitrogen, then we have any zinc, copper, manganese, stress. Stress is very important factor that cause predisposition to the fungal infection. So these are the traits that helps in the development of the fungal candidal infection. Any stresses, if person is under stress, that cause predisposition. Any change in the pH level is important, and then some chemicals and the carbon and nitrogen level. So all that is responsible for the candidal infection. It exists in two forms, dimorphism. I mentioned we have unicellular yeast bud form, multicellular, the pseudohyphae form from the bud yeast. They are attached to one another, and then there is switching between the bud and the pseudohyphae, and this switching is again both ways. Bud can become, which is white, can become opaque, which is the pseudohyphae. Next, we will go over some hematogenously disseminated candidiasis and what are the predisposing factor. As I mentioned before, lot of predisposing factors have to do with the immune system. So any condition that affects the immune system of the individual predisposed to the candidal infection, which is the normal flora of the body. So what are some predisposing factors for the candidal infection? Use of antibiotics. It's a very, very common factor. People who are using antibiotic for a long period of time, usually their immune system becomes weak, and these individuals are predisposed to candidal infection. And antibiotics are so commonly used for different conditions and infections. So if we see that, then candidiasis is not very uncommon as well. So it's a common predisposing factor, use of antibiotics, especially very strong antibiotics. Then any abdominal and thoracic surgeries which are performed on the abdomen and the chest, they are a predisposing factor for the candidal infection. Then IV and urinary catheters. Individuals who have catheters, whether they are intravenous catheter or the urinary catheters, it is a predisposing factor. As we mentioned in the previous slide also, there is a biofilm formation. There is accumulation of the fungi on top of the catheter, and its form or it gives a surface for the formation of the biofilm, and it can cause the candidiasis. So catheter is another predisposing factor. Then cytotoxic chemotherapy, again chemotherapeutic drugs, which are the drugs which are used for the cancers, different malignancies. They are the drugs which cause the neutropenia. They affect the bone marrow, and they cause the affect the cells which are helpful in the destruction of the microorganism, and that lowers the immune response and cause predisposition, or it's a predisposing factor for the candidal infection. Then hyperalimentation fluids which are used for giving the nutrition to the person is again hyperalimentation. Fluid use can cause predisposition to the candidal infection. Parenteral glucocorticoids, steroids, again is the predisposing factor. Severe burns. Severe burns is a very bad condition that can cause septicemia, and it can be very fatal, spread to different parts of the body, infection. And for severe burns, we need massive, severe antibiotic therapy, and again that's a predisposing factor. So burn itself is a condition in which the immune system becomes very weak also. HIV, again, very common condition. With the rise of HIV, the conditions like candidiasis becomes very common, besides the conditions or infections like tuberculosis, which was at a fall or it was eradicated to some extent. It's again at the rise because HIV cause predisposition to different infections, and it weakens the immune response. Immunosuppressive agents, again, any patient who is on artificial respirator, they are predisposed. Neutropenia. Neutropenia, as I mentioned, neutrophils are the cells which are responsible for killing or destroying the microorganism. Neutropenia is decrease in the level of neutrophils, and when there is decrease in the neutrophil, there is a predisposition to the fungal infection, and then candida is common. Then low birth weight babies who are born low birth, their immune system is not developed, and again they are very, very prone to the candidiasis. And then diabetes, one of the very common condition that can predispose to the candidiasis is the diabetes mellitus. So all these conditions are very common that predisposed to the candidiasis, and the Candida albicans is the most common species that causes candidiasis, and the main reason behind all these conditions is the decrease in the immune response. Because the candida is the normal flora of the body, it is present in the body without causing any harm or damage to the body, but once the infection or the immune system becomes weak, then the infection occurs, and this is known as the candidiasis. Next, the pathogenesis of candidiasis. Again, we mentioned before also there is adhesion, then there is damage and entry, and then it reaches the different parts and reaches the blood cells and cause damage to the host cells. So adhesion is the first step in the pathogenesis, and these are the fungi, the yeast form, bud forms that gives to the pseudohyphae that penetrate the cells, host cells, and then once they penetrate the host cell, it causes damage to the endothelial lining of the blood vessels and reaches the bloodstream, and through the bloodstream then it can become a disseminated type of candidal infection. So adhesion, with the help of glycoproteins present in the candida, they are attached to the host cell. First adhesion, then invasion. You can see it invade the host cells, and then it spread to the bloodstream. Yeast seeding into bloodstream. Through the invasion, it seeds into the bloodstream. These are the blood vessels, and then it causes endothelial colonization. It caused the colonization or spread into the endothelial lining, which is the lining of the blood vessel. Once it is colonized there, it caused invasion of that endothelial lining and cause a spread. So first adhesion, then invasion, then seeding into the bloodstream, and then endothelial colonization. So next is the colonization of the fungi or candida. As we already mentioned that it causes, after the seeding into the bloodstream, it causes the endothelial colonization. And in this endothelial colonization, there is increased candida in the endothelial lining, and it invades that endothelial lining and it reaches the different parts. And then once in the gut, then it is antagonized by the gut flora. And then once the antagonism by the gut flora occurs, then this causes the low fungal load or decrease level of the fungi because of the antagonism by the gut flora. And then we have the shielding of, there is pathogen associated molecular pattern, and this pathogen associated molecular patterns, this helps in the recognition by the cells which are capable of destroying or causing the destruction or engulfment of the microorganism. And these cells are the dendritic cells. Dendritic cells are the cells which are helpful in the destruction of the microorganism. And then very important is the macrophage. So both these cells, they are capable of destroying the microorganism, and then shielding of pathogen associated molecular patterns which is recognized by these cells, it assists in the destruction of the microorganism. Then after that we have the invasion. So invasion is the, here you can see once there is invasion of the host cell occur, then we have the T helper 17 cell. T helper cells are the cells which help in the functioning of the T cells. And T cells are the most important cells of the immune system. The conditions like HIV, AIDS, they cause decreased number of T cells. They cause suppression of the T cells, and that's why the person is more predisposed to different infections. So T helper cells are affected, and then they cause release of the interleukin 17. Then we have the caspase 1 inflammasome. That's the inflammasome which is cause interleukin 1 beta, interleukin 6, and interleukin 23. So all these are the chemical mediators. These are the chemical mediators. Once inflammasome is produced, this inflammasome is the macrophage. You can see in this structure, that's the macrophage to which the fungi is attached, and this causes the engulfing or destruction or ingestion of the microorganism, and with the ingestion of microorganism it is called the inflammasome is formed. And this is by, there is release of chemical mediators, different interleukins which help in the destruction or mediation of inflammatory response. And then also there is neutrophil killing that this is the neutrophil killing of the microorganism. So if we summarize these 3 steps, we have these are all together, that's the pathogenesis of the candidiasis, how the candidal infection develops. First, there is adhesion of the candida to the host cells, to the lining of the host, to the host cell. So after the adhesion with the help of glycoproteins, it becomes invaded, it invades the host cells, it can access to the bloodstream, it becomes colonized in the endothelial lining, and then after the colonization, now they need to be destroyed by the defense mechanism of the human body. So in the normal body or the person with normal immune response, we have cells like macrophages, and then we have dendritic cells which assist in the killing of these microorganisms. So in the normal immune response, the macrophage and the dendritic cell, in response to the pathogen-associated molecular patterns which are recognized by these cells, they attack the microorganism, they engulf the microorganism, and they release different chemical mediators that helps in the killing of these microorganisms, and they are destroyed by the neutrophils also. So that's just the summary of how this candidal infection develops. And then there is also damage cytokine. These are all the chemical mediators that are released as a result of inflammatory response, and they help in the killing of the microorganism. Interleukin 22 is also another cytokine. And then these are the defensins. So that's the chemical mediators. There is T helper cell 17 cell. There is interleukin 17, neutrophil killing of the microorganism. From the inflammasome, we have also interleukin 22. This interleukin 22 cross the host cells, and this function as the defensins, and it defend against the yeast buds which are not even invaded, which did not invade the host cell. So it can protect the body against the invasion of the fungi. So that's how the pathogenesis of candidal infection occurs. Next, some clinical manifestations of the candidiasis. First, we have the mucocutaneous candidiasis. Mucocutaneous candidiasis is oral candidiasis known as the oral thrush. Very, very common condition, oral thrush. There is fissuring. Fissuring in the angle of the mouth is very common, that causes pain, and it says the fissuring is in this region. And there is white coating of the tongue. This white coating is, once the tongue is rubbed with the tissue or anything, this white coating can be removed. So that's the very, very significant feature of the candidiasis. Oral thrush, you can see there is fissuring at the angle of the mouth. This oral thrush, it can be confluent or it can be discrete, separate, or it is mixed together. So these are the characteristics of the oral thrush. Painless. Usually this white coating is painless. There is no pain. Adherent It is adherent to the tongue, so it attaches to the tongue. And once the coat is removed, you wipe it out, it removes. So it is adherent, or it is on the top, attached to the skin. It is white in color. So all these are characteristics of the oral thrush. There is fissuring, it is white in color, it can be discrete or confluent, and it's painless. So all these are characteristics, and that's the picture how the oral thrush appears. Again, the close-up of the oral thrush, that's the white coating of the tongue, you can see, and that's the characteristic or very specific feature of the oral thrush. Next, we have vulvovaginal candidiasis. Again, one very common condition. Usually, if there is poor hygiene and during pregnancy, after the birth, this candidiasis is very common. There is pruritus, itching. There is pain, and there is vaginal discharge, and this discharge is thick, curdy white discharge that is very, very characteristic of the candidiasis or vulvovaginal candidiasis. That's the picture of the Candida flora, and we already mentioned this as the budding yeast form, and then we have the hyphae or pseudo hyphae. So there is itching, very bad itching, pain, vaginal discharge, different conditions, PIDs, pelvic inflammatory diseases. There is patients who use antibiotics, steroids. During pregnancy, these conditions are very, very common. Next, Candida skin infections. Different skin conditions can occur as a result of the Candida infection or as a result of candidiasis. That's the paronychia. Paronychia is at the margin of the nail. You can see this is the paronychia, and it's very painful condition. This as a result of the candidal infection, paronychia. Then onychomycosis. Onycho is for the nail. Mycosis is for the fungal infection. And again, this onychomycosis is common to see this condition in the outpatient, and usually patients have this onychomycosis as a result of the fungal infection. Intertrigo, again it's a common condition in between the fingers. This intertrigo is common and it's painful, and there is sometimes discharge from this intertrigo, and it's very important to manage and take care of this condition. So intertrigo in between the fingers. Balanitis is the condition of the penile condition, and it's you can see there's the appearance of the fungal infection, balanitis. Next manifestation of the skin as a result of candidal infection is erosio interdigitalis blastomycetica, and this involves the structure in between the digits, and it resembles intertrigo, but that usually is in the toes, between the toes, and this is between the fingers, you can see, but the appearance of both these conditions is the same. Then we have another condition known as folliculitis. And this folliculitis, you can see there is a reddening and there is like a rash appearance after. You can see like this rash after the drug allergies. So this is also common after the fungal infection, folliculitis, inflammation of the hair follicles, the folliculitis. Then perianal candidiasis. Perianal candidiasis, you can see around the anal region there is redness, scoring and itchiness, and that is also common, especially patients or in children who have fecal incontinence and who wear the diapers. This condition is very common. There is perianal candidiasis. Then diaper rash, again, as I mentioned, is also a common condition which predisposed to the candidal infection, and there is redness, itchiness, and to manage this, usually the rash cream is used, and then avoidance of the diaper for a few days is important to prevent that constant irritation or infection. So these are all the common candidal skin infections or manifestations. Next, some chronic mucocutaneous candidiasis examples and how it present. We have heterogeneous infection of hair, nails, skin, and mucous membrane. So, as a chronic infection like onychomycosis. Onychomycosis occur as a result of chronic candidal infection. It is not the example of acute infection like vulvovaginal candidiasis. It takes a time for this to develop. Then again, intertrigo, like exophytic outgrowths on the skin, like this. Again, that's an example of the chronic mucocutaneous candidiasis. And then autoimmune polyendocrinopathy candidiasis, ectodermal dystrophy syndrome. So autoimmune polyendocrinopathy, as the name shows, is the autoimmune polyendocrinopathy. So polyendocrinopathy, it involves the multiple glands and hormones which are responsible for polyendocrinopathy candidiasis, ectodermal dystrophy, and it causes dystrophy of the ectodermal layer, and this is together known as the APECED, which is autoimmune polyendocrinopathy candidiasis ectodermal dystrophy syndrome. Next is deeply invasive candidiasis. Deeply invasive candidiasis, if it is the gut, from the gut to the blood vessels which invade deeply. First, there is adhesion and colonization. So we already mentioned about the pathogenesis and how the spread of candidiasis occur. There is adhesion, then invasion, then there is seeding into the blood vessels, bloodstream, and there is endothelial colonization, and then invasion into the blood vessels, and but through that it can spread to the different parts of the body and can cause deeply invasive candidiasis. So hyphal penetration and invasion, and then vascular dissemination. So it's just the summarization of all these steps we already mentioned. First, there is adhesion and colonization. Then there is hyphae formation, and there is hyphal invasion, and then vascular dissemination. Candidemia Emia is the spread of infection in the blood. Once there is invasion of the blood vessel and infection reaches the bloodstream, it is known as candidemia. Now, different features of the invasive candidiasis. If it's in the abdominal cavity, we have abscess, pancreatitis, peritonitis. So there is pus formation, abscess, pancreatitis, which is inflammation of the pancreas, and peritonitis, inflammation of the peritoneum, which is the covering of the abdominal organs. And once there is peritonitis, there is all pain and guarding and rigidity because of inflammation of the peritoneum. Next, deeply invasive candidiasis examples. If it reaches the bone, we have osteomyelitis, spondylodiscitis. Both are involvement of the bones. There is inflammation of the bones. If it reaches the brain, then brain abscess and meningoencephalitis, inflammation of the meninges and the brain parenchyma. If it reaches the eye, choroiditis, retinitis, and endophthalmitis. All these are different involvement of the choroid, retina, and there is endophthalmus. Exophthalmus is bulging of the eyeball. Endophthalmus is the retraction of the eyeball. Heart, it can cause endocarditis, inflammation of the endocardium of the heart. Then the kidney, it causes candiduria, pyelonephritis, pyonephrosis, renal abscess. So you can see that candida, even though it's a mild infection caused by the flora, which is the normal flora of the body, which usually is not associated with any pathogenicity or any pathological condition, but once the immune system becomes weak and it becomes an invasive form, it can spread to different parts of the body and cause serious manifestations. So in the kidney, it causes pus formation, inflammation of the renal pelvis, and there is also pyonephrosis. If spread to the liver and spleen, cause chronic disseminated candidiasis and focal abscess formation. Lung again cause focal abscess. So all these are the examples of deeply invasive candidiasis. And once it reaches the bloodstream, it spread to the different parts of the body and cause deeply invasive candidiasis. That's the picture of deeply invasive candidiasis. One is spread to the eyes, and then you can see the presentation on the legs of deeply invasive candidiasis. Diagnosis, we have visualization of pseudo-hyphae or hyphae. That's very, very specific diagnostic factor if we see the pseudo-hyphae or hyphae. And this is by the wet mount. Wet mount preparation, saline and 10% potassium hydroxide. That's the very common preparation for visualization of pseudo-hyphae and hyphae. Then tissue gram stain, periodic acid shift stain, PAS, methenamine silver stain, and visualization from sputum, urine, or peritoneal catheters and blood. So that's the diagnosis by visualization of hyphae and pseudo-hyphae, and different stains are used. Wet mount preparation is very common for the Candida. We have tissue gram stain, PAS, methenamine, and growth from the sputum, urine, or peritoneal catheters and blood. Next, also the diagnosis, you can see very characteristic appearance of the yeast buds. That's how you can see the picture of the candidal infection. Next, treatment of the candidal infection, mucocutaneous candida infection. The preferred treatment is topical azole. Topical azole is used preferably. Alternative treatment is topical nystatin. These are all the antifungal ointments. For vulvovaginal candidal infection, we used oral fluconazole 150 milligram, azole cream or suppository. Nystatin suppository. For thrush, clotrimazole troches and nystatin fluconazole is used. Then for esophageal infection, fluconazole tablets or itraconazole solution or caspofungin, micafungin or amphotericin B. So all these are the treatments for different candidal infections. Next treatment for disseminated candidiasis, amphotericin B and deoxycholate. Amphotericin B lipid formulation, fluconazole, voriconazole, caspofungin, anidulafungin, and micafungin.